Hi, welcome to TCT 2023. I'm Margaret McIntyre from Columbia University in New York, and I'm here with my good friends and colleagues Ziad Ali and Darshan Doshi, and we're going to have an interesting discussion for you today around the calcium space. So Ziad, I thought I'd start with you. So what I wanted to ask you about in light of your very recent publication was around the issue of eccentric calcium. So it kind of feels to me that over the last few years, we've really mastered how to deal with concentric calcium, how to assess it, how to choose devices to treat it. And now I think our attention's kind of shifted to what we do about eccentric calcium. I just wondered if you'd shed a bit of light for us on, how big a problem that is, how we decide when it needs to be treated and modified, and if it does, what devices are available and how they work and the efficacy, fill us in on your recent data.
Yeah, thanks, Margaret. So the rationale behind investigating was actually our assessments of the previous studies, particularly Prepare Calc. So when we looked at why there might not be a difference in some of the head-to-head trials of atherectomy versus balloon, interestingly, we found out that the minimal stent area was very similar, but the minimal stent area is ending up outside of the segment of calcium modification. So we found this phenomenon to be rather peculiar because we spend a lot of time focusing on the most calcified segment. So, you have a lesion, it's heavily calcified, we take our atherectomy burr in there, we really go to town on it, we break it open with a big NC balloon, that's usually like 8 or 10 millimeters of space, but then we put a 38 millimeter stent. And it turned out that the minimal stent area ended up outside of the maximum calcified segment, somewhere remote. And this recurring phenomena came up that it was usually in an area of eccentric calcification that provided some recoil that either the operator couldn't modify because of the devices or didn't because they just didn't think it was important. And so that led to this sort of our rethinking about the way we should do lesion preparation, which should not be calcium preparation, it really should be lesion preparation, the entire calcified segment. And if you remember, Margaret, in the Disrupt studies, when we did the core lab analysis, the length of calcium is longer than the lesion.
Yeah.
And that's the sort of, people used to say, how's that possible? The reviewers used to bring it up too, what's going on there? And it goes to show you exactly that calcium modification needs to occur throughout the lesion because the minimal stent area happens remotely. So what did we do next? Well, what we did is, knowing that information, we went ahead and looked to see how in particular Shockwave would work in eccentric calcium versus concentric calcium. Now, we're busy operators and we know the following phenomena. That is, there are multiple calcium morphologies within any calcified lesion. There's some concentric, there's some long, there's some bits and pieces, and all of them impact the compliance of the vessel, but also the ability to expand. What we found was that irrespective of the amount of calcification, the stent expansion and minimal stent expansion and MSA after Shockwave was the same. So this was a little bit different from what we've seen before, and it led to this sort of new concept that we've been teaching, and that is, if it gets metal on top of it, it gets shocked. What's really interesting about calcification, and some of the reviewers brought up, which we thought was also meaningful, is they're like, well, how do you need to modify it anyway? Just as much as we need to know when we don't need to modify it, we don't know when we need to modify it. And so, since you're going to put metal on top of it anyway, it makes a lot more sense to do lesion preparation throughout. So that was the premise behind why we did the investigation. Our ultimate findings were that Shockwave works in magnitude to the amount of calcification. The more calcium you have, the more it fractures it. But if you have 90 degrees or 180 degrees, the energy that goes into that still can lead to fracture, and that modification can lead to an improved expansion.
Yeah. So really interesting. And I suppose the thing that a lot of people will ask is, where's that threshold? How much eccentric calcium, how thick, how big an arc, and I think for me, that's still an area that's difficult, isn't it? But as you say, the worst thing that can happen is you don't treat it, and then you end up with an underexpanded stent. I think the way you describe how we got to where we have with the analysis from Disrupt leads quite nicely into the availability of the C2 Plus, Darshan. So just following on from what Ziad said about the whole lesion treatment, how have you found with your first use with C2 Plus?
Yeah, so I think the C2 Plus is a welcomed addition to our armamentarium. So the fact that the C2 Plus catheter allows for 120 pulses as opposed to the 80 pulses with the prior C2 catheter, I think is very advantageous. And I think it's advantageous in 3 specific subsets. The first is one where you have long diffuse disease and you need your additional pulses. So sometimes 80 just won't cut it, and having those extra 40 pulses I think is very advantageous. The second is when you have eccentric or nodular calcium, and as Ziad presented at TCT last year and in his manuscript, that those are the calcium subsets where you need to spend a lot more in terms of pulses in order to get appropriate fracture and stent expansion. And so having those extra 40 I think help. And then another potential subset is potentially bifurcations, where if you have a left main potentially or an LAD diag and you need to ration pulses, the fact that you have more allows for you to be able to completely crack that calcium and get the appropriate stent expansion. And so I think that the fact that we now have more pulses is advantageous to what we need to do in terms of preparing the vessel before we stent.
Yeah, it's kind of taken away, that situation before where you've got a long LAD and you're thinking, okay, I'll give 20 there, I'll give 20 there, I need to save 40 for the left main of the ostium of the LAD, and you're kind of in your mind, you feel you're cutting yourself short a little bit in the treatment, so it takes away that anxiety or the need then to get a second balloon out, which obviously can lead to increased expense in the procedure. And I think also with the increased awareness of using guide extensions and things in the case, it also allows you to use it in multiple vessels. Yeah, so have you done that so far?
Yeah, so I think that, going back to Ziad's analysis where the MSA wasn't at the most calcified area but was at some other point in the vessel, the fact that you now have this catheter that gives you more pulses, I'm hoping that that's not what we see anymore, that we're able to actually take care of the entirety of the vessel. The other part is that the C2 Plus and go through a 5 French guide extender as well, which I think is advantageous for multiple reasons. And so when you need to go distally, you need to do, say you have a long calcified RCA, and you got to go very far into the PDA and then go all the way back. You had a live case today of a right coronary that was super calcified. In a case like that, using the C2 Plus would have been very helpful for sure.
And I think if we think back to when we first had IVL available, there was all that initial anxiety with a new device that can it cause harm? If you use it in a segment of the vessel that's less calcified, will it cause harm? And I think what we've understood from the data now is that actually, if you have eccentricity and you're not sure about whether it needs to be modified or not, actually using it in those segments of the vessel certainly appear to be safe. And certainly, Ziad, from the paper, can you reflect on that in terms of the safety aspect of it?
Yeah, so absolutely. There's a couple of things we like. There's no point taking pulses home, right? And then second is the fact that C2 Plus is now available, it allows us to do vessel prep instead of lesion prep, right? So you prepare the entire area. So the C2 Plus has actually changed the way we do lesion modification using IVL now. And so previously what we would do is we'd go and do the classic power surge. We'd get into the lesion, put 40, 50 pulses, and now you've got an inflated balloon. It's hard to move distally, so you'd have to manipulate a little bit. Sometimes you couldn't get it back, and maybe that led to a little bit of a suboptimal result. Now we've just changed. So we go in, we go most distal, we start distal, we pulse backwards until we get to the lesion. Again, we drop our power surge, 60, 70 pulses in that area. And essentially what that does is it gives us those 40 extra pulses that we didn't have before, and we use it across the lesion. So for our practice, it's actually changed the way in the order we do lesion prep. Start distally, come all the way up. We use a guide extension all the time, and then we redeliver it to the maximum calcified segment and exhaust our pulses. What's the rationale? The more pulses you give, the more fracture you get. the more fracture you get, the more compliant the vessel gets.
Yeah, just to dovetail off of that, you know, the way that we used to do it, when you had to ration out those pulses a little bit more specifically, the way we would do it was, you know, to go with an NC balloon and then figure out the areas and co-register that with Cine to figure out where you really had to deliver those pulses. Now with the extra pulses, you don't have to be as meticulous about that. And back to his analysis, I think it may actually lead to better outcomes, and your MSAs may be much bigger as a result throughout the vessel.
Yeah, and I think the word compliance you brought up there, Ziad, I think beyond just our previous focus being on these very focal areas of napkin rings or thick plates, now they're actually increasing the whole compliance of the vessel, improving stent delivery, stent expansion, even the way the stent can function and move
Absolutely.
with the vessel in a more natural manner. I think we haven't really talked much about that, about how it actually affects the whole dynamics of the artery. What's your thoughts on that?
I mean, as you know, there's very good data on vasomotion, and it's important. And we also know that stents in general, especially calcified arteries, lose that ability. The turbulence of flow can impact recurrent atherosclerosis and in-stent restenosis. And we're really modifying that by doing this. And I would say from a biology point of view, the real iteration of C2 Plus is, as you mentioned, it's a change in vascular compliance of the entire vessel, not just the lesion. Yeah. And I think that's the sort of way it was naturally made to be formed, so could lead potentially to improved clinical outcomes.
Okay, well, thank you both for a really informative discussion. If you want to read more about IVL and eccentric calcium, check out Ziad's paper, just published this month, and enjoy using the C2 Plus. It's a really great addition to the toolkit. Thank you.